Chase.
Thank you, Dr. Amita. Not a doctor yet. My name's Chase McKevitt. I'm a fourth-year osteopathic medical student working as a research trainee with Dr. Chaichana, and it's a pleasure to present this case this morning. Before we begin, listed on the slide here are all the team members who took part in taking care of the patient we are presenting. Thank you for your wonderful care. And our case is focused around a 69-year-old female who initially presented in June of 2022 with gait instability and lightheadedness. And she reported over the previous year that she had these episodic spells of feeling unsteady in her feet as she was going to fall. However, she had never experienced an actual fall. She also noticed that she had enlargement of her nose and jaw. However, she couldn't put a specific time frame when these changes occurred. Additionally, she admitted to an increase in her shoe size from an 8.5 to a 9.5. But again, she couldn't recall a specific time period when this change occurred. She was complaining of swelling in her hands and her wrists bilaterally. However, the left hand was more pronounced and she did have numbness in this hand. Other pertinent positives on her review of systems included generalized fatigue, weight gain greater than 10 pounds, frequent headaches, which began 3 months prior to presentation, and arthralgias of her joints. Her past medical history was significant for hypertension, which was being managed with a combination of a beta blocker and a thiazide diuretic, and hyperlipidemia being managed with a statin. Her family history was significant for colorectal cancer in her mother, sister, and brother. On physical examination, she did have a elevated blood pressure of 145/77, and she is compliant with her antihypertensive medications. She had coarse facial features, progathism, and spade-like hands. The remainder of her physical exam, including her neuro exam, was unremarkable. So given that she was having these dizzy spells and lightheadedness and gait instability, a CT head with contrast was ordered. The patient was unable to undergo an MRI study due to metal implantations in her right leg and ankle from a previous fracture fixation. On the left is the coronal, and we can see that there is a hyperdense sellar lesion with suprasellar extension, and it measures approximately 3 centimeters in its largest diameter. It does appear to abut the optic chiasm. And if we see here, there is a focal area of necrosis in the suprasellar area on the right side. It does appear that the lesion extends bilaterally to the cavernous sinus. However, it's hard to truly gauge cavernous sinus invasion given this modality. Dr. Reiner, would you like to comment on the coronal?
Well, I want to comment on the fact that she has been told she can't have an MRI. That's very hard for me to believe. If you have a patient who tells you that, give us a call, because there's very little that can happen in the leg that would preclude an MRI. This is such a large adenoma that, I think we can tease out most of the things you need to see, but I question the fact that she says she can't have an MRI.
We will keep that in mind for the future. And the sagittal here, we could see again the same hyperdense lesion. And then on the right side, we could see in this image the focal area of necrosis in the suprasellar area. And it does appear that the anterior wall of the sella is thinned. Any comments on the sagittal, Dr. Reiner?
No, I think you've described it well. With respect to cavernous sinus invasion on CT, we could definitely do a CT angiogram, and I think that would pretty nicely show whether there's cavernous sinus invasion or not. We could almost pretend it's an MRI.
Gotcha. Thank you. And then CT sinuses were obtained for operative planning. Here's the axial. We can see that the patient has a rightward septal deviation. And then on the coronal, we can see a large intersinus septation. And there's thinning of the sella floor on the right side. Dr. Omita, would you like to comment on the CT of her sinus?
So, basically the thinning of the cell, the sella floor on the right side, if you get to that point, you see that here you got this inferior lateral extension towards the right side. And then if you go to the CT coronal soft tissue,
I don't have the CT coronal, so I'll have
No,
to
like
share
the
that.
previous slide that you had.
Oh, sorry.
You go to the coronal, yeah, and you scroll
Mhm.
that. Okay, right there. So if you, then this is what you see. That's what we had right there. So this is the supercellular component, right, that we were talking about. And if we
Mm.
scroll a bit more, okay, so here you got, you know, the upper part of the clinoidal ICA, and this on the side is going as a chew. The, you know, I suspect this I would classify as a NOSP chew, probably. Like, I think this is just pushing the medial wall rather than anything. But on this side here, there is this inferior lateral extension. That is this extension that you see here. This inferior lateral extension quite often will be like as a NOSP 3B, which is one that quite often goes through the medial wall itself and gets into the cavernous sinus. So quite often you have the, of course, you got the 3A, which goes above the horizontal segment of the cavernous ICA, and you have the 3B, which is the one that goes below that segment into the anterior wall. The 3As quite often, you know, they don't really, quite often don't invade the medial wall. So they're just pushing the wall. But the 3Bs, just the wall is more fragile on that aspect. So every time we see this inferior lateral extension in the relationship with the vertical segment of the ICA, quite often we actually do see a cavernous sinus component, so actual cavernous sinus invasion. So that is a component that will require us to have a more broad approach, or in terms of bone resection on the right side, and also to be able to get enough exposure to navigate around the cavernous sinus on that, and the cavernous carotid on that right side.
And JP, just to elaborate, because this is where I think Dr. Reiner's point sometimes of the MRI is important. Comment on that, and maybe you can just go back and forth on that image to see the carotid and to imagine the configuration, the three-dimensional reconstruction. So as we're planning surgery, obviously we want to get a sense. Can you just maybe take some arrows and point it for our audience right here so they can get a sense?
Absolutely. So let's get this one here. So scroll a bit more, Lois. I'm sorry, Chase. Come forward. Like, let's go all the way forward on this sinus. Yeah, anteriorly. Yeah, more. Okay, so here you can come back a bit. Go back a bit slowly. We're gonna identify the first component of the carotid, the most anterior. Go back. Go back. Okay, right there. Stop. So right here, this is where you got the clinoidal ICA on the right side curving. So this is the most anterior part of the carotid, of the entire carotid. That's the most ventral part, the most anterior part of it. And here it's already curving, because you see that there is this carotid component here, and the next one is already here. So in this area here, you got the transition with the so-called distal dural ring, which is going to be running right here. And then you see the same thing on the left side. And then this tumor is growing in this direction. If you scroll more, going backwards, Chase, you can see that the carotid is going to be curving on the side. Go more. More. Keep going. Let me delete this just for a second. Go. Okay, go back now. I mean, go back, I mean, come forward, I'm sorry. And then you're going to be seeing that this has been curving here. Keep going. And then you're going to see it here again. Okay, go.
Forward or backward?
No, in the same direction that you're going now, because you're coming towards the front now. Yeah. And then you can see the carotid, and the carotid is going to curve now. So you got the horizontal segment, and then you're going to see the clinoidal segment. So here is this relationship that is definitely so more difficult to see in the CT scan that you can observe. So every time you got this component that is going in close relationship with the vertical ascending ICA, is this one that often we see this relationship with the cav sinus on 3B, as we were discussing. So this inferior descent of the sella floor on this aspect is the one that, at least in my opinion, requires us to have this broader exposure, which you're going to see is very different from the exposure we had on the previous case. Certainly, so it's going to be easier to understand in a future case when we got the, actual MRI to describe this.
Okay. Beautiful. And then on the sagittal CT sinus of the bone, the patient had a post-cellular configuration of the sphenoid sinus and had well indentation of the sphenoid itself. So given that the patient had a cellular lesion identified on her CT scan, endocrinology was consulted, and here are her initial labs from November of 2022. Dr. Barsakova, would you like to comment?
Yeah, as we know, as we see right now, patient with clinical evidence already of the acromegaly has a biochemical evidence of the acromegaly with the elevated growth hormone significantly, which randomly, usually on the lower side, and insulin growth factor 1. The prolactin elevated, which probably likely due to stock effect, but also possible with co-secretion. Otherwise, she didn't really has any other, like pituitary deficiency. Oh, yeah, I think, just I forget to mention, sure, FSH and OH, if you see for postmenopausal, like women, it's abnormally normal because it's which suggesting with secondary hypogonadism, which I mean, she's in postmenopausal, so we don't really require the treatment. I think one of the other thing I would like to mention, which not related to neurosurgery, but we did notice what she has, hyperparathyroidism. I think I know like phosphorus, like kind of on a high level, but further, workup did suggest that she probably has more primary hyperparathyroidism, which actually leads us, like a suspicion for the multiple endocrine, syndrome, which is like MEN1, and where we actually need to genetic testing, because we know it's present usually with pituitary adenomas, with primary hyperparathyroidism, but also a patient has a risk of different, multiple neuroendocrine tumors, and that's why they usually require the genetic testing. We're going to be sending her for genetic testing, like just, to make sure she doesn't have, because she will need, because further, monitoring, because some tumor, pancreatic tumor can be non-functional tumor.
Could I add a comment to that, Yulia?
Yeah.
Okay. So given her age and later manifestation, I think the list is a little expanded into what I guess we call MEN4 right now, which is a another mutation that can occur in P27 or KIP1. So that's a tumor suppressor involved in cell cycle regulation. And the other thing is, parathyroid disease is a disease as we age. And there can be cases where the patient happens to have a pituitary tumor, but they also have hyperparathyroidism. And the difference there would be that for MEN syndromes, this should be hyperplasia. And for, aging hyperparathyroidism, I'd expect an adenoma. So continuing to work that up is key, and imaging would be very helpful to know if it's diffuse hyperplasia versus a strong signal for a single large adenoma. But she's very interesting, and I agree she needs to have genetic testing.
Thank you. Given the patient had compression of her optic chiasm on her CT scan, a visual field analysis was performed. Here we're looking at it as if the patient was looking into the machine itself. So on the left side, we have the patient's left eye, and on the right side, we have the patient's right eye. First, we want to look at the reliability indices, which are located here at the top. And this just measures how well the patient was able to perform the test. On the right side, she had a higher level of fixation loss compared to the left, but overall, she had good reliability. If we look at the plot next to the grayscale, these data points represent the visual threshold in each visual field tested. And the higher the number, the dimmer the light the patient could see in that visual field, which is correlates to a better result. The lower the number, the brighter the light the patient was required to see, which results to a poorer test result. So if we look here, compared to the patient's medial nasal visual fields, the temporal fields had lower data points bilaterally, more pronounced in the superior quadrant. And then if we look at the total deviation plot, this looks how this compares the patient to aged matched patients with normal visual fields. And the more negative the number, the more deviations away from normal the patient is, which signifies a poorer test. Here again, we could see bilaterally in the superior temporal visual fields, she scored with very low negative numbers. more pronounced in the superior quadrant than the inferior quadrant. And then if we look at the pattern deviation, this can differentiate between the gross visual field losses and focal visual field losses. And here we could see that it is more pronounced, again, in the superior temporal fields bilaterally, but also in the inferior temporal fields bilaterally. And this is consistent with a bitemporal hemianopsia. Just Dr. Eggenberger on the line. Would you like to make any comments?
No, that was a perfect description. She has a pretty well characterized superior greater than inferior bitemporal defect that really fits the anatomy as displayed by the imaging.
Okay.
I gotta say that was an excellent description, Chase. I'm just learning a bunch of things from you right now.
Eric, when I describe it like that, I'm reading your notes. So that was amazing, you know, and I don't think he was reading your notes, so that was great.
Yeah, I mean, I usually just look at the, you know, I'm like a 5-year-old kid. I mean, I just look at the colors, you know, that's kind of, okay,
That's right.
yeah, black and white, and that's it.
Yeah.
You know, but I never really understood the numbers. So thank you for explaining it to me today.
Yeah, I had a lesson with Dr. Eggenberger yesterday, so we went over it, and I feel a lot more comfortable reading these now.
Yeah.
So
Thanks, Dr. Hagenberger. And I have to say, I think that speaks a lot in the quality of the neuro-ophthalmology team that we have here. There was a, you know, a great session this week as well. And, you know, like it really takes it to another level. You know, I've been in other places, and I think that understanding of those concepts here is just, I have to say, deeper than in other great places. And so, but so it's fantastic. Great work, Dr. Hagenberger, Dr. Pleasant, and great work, Dr. McAvitt. Go ahead.
Yeah, no, that was all Chase. Chase did that. That was a really good job.
And just to emphasize that, I mean, everybody knows both Susan and I led 2 major programs at 2 major institutions, and the quality of our neuro-ophthalmology team is several standard deviations above those other major centers. And I think, you know, Dr. Pleasant, Dr. Eggenberger, they do an amazing job in teaching our residents, providing care for our patients that are extraordinarily complex. And I see Susan smiling there as well.
Well, because they even order endocrine labs, as Dr.
That's
Pless
right.
did this week.
So amazing. So thank you guys for allowing us to learn from you.
We are delighted to be on this team. It's just a wonderful place to practice and great people to work with.
So moving forward, given the patient had biochemical evidence of growth hormone access, a pituitary lesion on her CT scan, and clinical findings consistent with acromegaly, the diagnosis of acromegaly was made. The most probable etiology of her disease is a pituitary adenoma somatotrophic type. However, as Dr. Varsakova mentioned, she did have elevation in her prolactin levels, which could represent the stalk effect due to compression of the infundibulum, but it could also be a sign of a co-secreting tumor with growth hormone and prolactin, which is known as a mammosomatotroph type pituitary adenoma. Other less likely diagnoses include an intracellular meningioma or metastasis or a craniopharyngioma. So to recap, this is a 69-year-old female with a supracellular mass, biochemical and clinical findings suggestive of acromegaly. She was offered endoscopic endonasal transsphenoidal approach with the goals of optic chiasm decompression, disease control, and obtaining tissue for diagnosis. Other options included a transcranial approach, radiation therapy, or medical management with a somatostatin analog. The potential risks and complications are listed on the slide. For the sake of time, we will move forward to the operative video. Here, the injection of local epinephrine to control bleeding, reduction of the middle turbinates bilaterally.
Chase, if you don't mind, I see that Dr. Olomo is here with us. Maybe
he is?
let's go.
Yeah,
I just saw here. Yeah. Let Noma, would you like to describe to us a bit of the techniques used for this approach?
Oh, sure. So this is a very large lesion, and so we need a wide approach. And so I am going to remove the concha bullosa or swelling of the middle turbinates to provide better access to the sphenoid motor recess. I do that on both sides. So that's what I'm doing right there, reducing the middle turbinates, finding the sphenoid os there. So that's the sphenoid os, which is a primary landmark. Next, I'm going to outline the pedicles for a nasal septal flap, and then elevate a nasal septal flap. Because of the size of the lesion, we're anticipating a possible CSF leak. So I'm going to elevate that flap and preserve that for reconstruction of the skull base at the end of the case. So there I'm tucking the flap into the nasopharynx. I always preserve the pedicle for the flap on the contralateral side, just in case we need that as well. So next, just removing the mucosa from the sphenoid sinus, and then really expanding that sphenoidotomy all the way to the plenum sphenoidale superiorly, and then inferiorly to the floor of the sphenoid sinus to provide the widest possible access. And then here, we're starting drilling of the cella.
Yeah, no, okay, now stop the video for a second, Chase. Yeah, and I just want to say, I mean, you see that the exposure we got here, the sphenoid, is only possible by the beautiful work that Dr. Olomo did in this case, and really expanding the corridor. So as you were saying, like he navigates. If it's a microadenoma, some of the maneuvers are not necessary. This is a much bigger case, needs further exposure. So I think you did a partial or a posterior ethmoidectomy in this case as well, Noma. Do you remember?
Yes, I did. I also did a posterior ethmoidectomy to provide those lateral access.
Yeah, and you see, like, this really makes a world difference for us, like, and of course the flaps as he described, like this is just allows us to do this work. So you're gonna see in the video that we have a very lateral exposure on the right side, which is what we need to work in the cavernous sinus. And then we also have the optic carotid recess on the left side. Without that, even if we could see, we wouldn't be able to maneuver our instruments. So that approach is really key to the success of this operation.
And
So
maybe just let me make a comment, because I've been a witness and I've benefited from both of you guys' work in the operating room. So just imagine you're working through a tunnel that is probably a centimeter in diameter at the most, and you have long instruments that are probably 12, 15 centimeters in length, and you're working right next to the carotid into the skull base, and you have to maneuver, and you have to, when you look at the camera, you see the camera borders right there. But the instruments don't necessarily move all the way, to be able to reach. So you really have to make those exposures in that tunnel to be able to manipulate. And 1 or 2 or 3 millimeters can make a difference distally of a half a centimeter or sometimes even a centimeter to be able to reach and to have control, especially if you were to get into a situation with internal carotid, which could be devastating and fatal for a patient. So just keep that in mind, because what you're seeing right here is pure art, in my opinion. Is beautiful, absolutely stunning work. So congratulations to both of you.
thanks, Dr. Q, and thanks, Dr. Olomo. So maybe let's play the video. So as you see, as we transition, as Dr. Olomo had finished the opening of the sphenoid, a wide sphenoidotomy, now we're drilling the bone, and the first thing we do is to remove that bone out of the sella. You see that is expanded, and then we're going to go all the way to the limbus sphenoidalis, so to the junction between the cell and the suprasellar space. We don't need to go above that, but we need to go on the right side. So we start drilling the bone in the inferior lateral space, and then we go from bottom up to unroof the carotid. Stop the video for a second there. Can you go back for a moment? Or even right there is fine, yeah. So here what you see, I think it's somewhat easy to notice here, you got this dura, which is expanded because you got the tumor, of course. You got here, this is the clinoidal ICA. We got, this is going to be the region of the distal dura ring. And of course, then therefore this space is going to be suprasellar space. And then you got the carotid, and this is the anterior wall of the cavernous sinus that is here. So in this space, you got the anterior genu that is going to be doing like this. And then here, you don't have anything here in this pocket. The carotid is going to be curving like this. And that's why this is often the safe spot to open it. And this vertical segment is behind, it's not in the front. So using this concept of anatomy, and as I was saying, this is more lateral than usual, you can navigate on this corridor. So you see the Doppler, that of course is mandatory for this approach. Without a Doppler, I don't think it would be safe to do those cases. And we're going to be mapping the carotid so we can continue the approach. So go ahead with the video, please. Then, just like the last case, opening the dura and then trying to mobilize that dura matter away from the tumor capsule, kind of to try to separate the planes. And that's important so we can facilitate the preservation of the pituitary gland as well, which in this case is pushed laterally to the left. And you see that I was using a Calvin knife to open the anterior wall of the cavernous sinus. We can mobilize this dura, and here we are in the transition between the cavernous sinus, the cavernous sinus and the sella. So in this case, we're gonna have to get that right side exposed. We need to get the left side exposed, and that's it. That's the view we're gonna start working with. We're gonna get some tumor to send to frozen and to get it to permanent as well. And then we're gonna be working with the 2 dissection technique to clean all the way to the dorsal sella. After that part is done, what we see here is we further opening the anterior wall of the cavernous sinus to open that space and to clean tumor from that anterior inferior space of the cavernous sinus. What you see right there, this segment that we are coagulating, this is one of the ligaments. This is likely the so-called inferior paracellular ligament that connects the medial wall to the sella. And then we're going to be opening that space. And here you can see, this is the vertical segment of the carotid that is already exposed right there.
And if I saw correctly, was that the Doppler that you were mapping right there, JP? Was that what I saw a second ago? Yeah, perfect.
Yeah, we had the Doppler all the time. So basically, in my opinion, the rule of the thumb is that you need to use sharp dissection. So in my opinion, there is no really a lot of option there. But to use sharp dissection safely in that space, you need to use the Doppler, because it's very easy to get into trouble if you don't map and identify the structures properly. And with the venous using, that happens. Like sometimes the Doppler, you can use a suction in one hand, the Doppler in the other hand. You map that area, you keep the suction with your left hand in that space, and then you can go with the scissor to cut once that Doppler had mapped the pathway of the carotid.
Absolutely. And I just wanted, as a comment right here, even for my own, I've been doing pituitary surgery for many, many years, and it was not until JP joined us that I really began to feel comfortable doing those maneuvers. The first few cases that I did with JP, I have to admit it, my heart rate was quite high, elevated, but I knew of his work. I've been watching him for years, and I was willing to be pushed beyond my, box. And I have to admit it, the cases that we have done are absolutely stunning. What you're seeing right there, I would say that probably only about 5 people in the world do it, like JP does it. Not too many people. And doing it well too, because we've done many. He can tell you the numbers. Very, very few people in the world can do that. So congratulations, beautiful work.
Thank you, boss. As you know, this is always teamwork. In this surgery, like even to do this, you see that there is a person with the instruments. In this case, it's me, and there is another surgeon with the camera. And here, like we're working with Dr. Chai Chen and working with Dr. Goyao, and there is no way to do this alone. So it's really like all about the teamwork. So to me, it's an honor to be here with you and with the team. So thank you. So let's keep going the video. And you see that now we start to interrogate and to inspect that suprasellar component, but we're not yet removing it, because I still want to clear up that right side of the cella. So we're going to be going from right side to the top, and then only then we're going to be starting to come on the left side. So that side of the carotid needs to be clean before we can mobilize from left. Once that is done, we can mobilize, and what you see here is the capsule of the tumor being peeled away with preservation of the diaphragma. So the diaphragm, the arachnoid, is coming towards us as the tumor is removed, and then we can get it out. And you see that the curettes, they can be very useful, but being used as a dissector really much more so than as a spoon, so to say. So since they're round curettes and non-cutting curettes, they allow us to do this dissection that I find personally very useful. With that being completed, you see the arachnoid being completely resected, no tumor in the right side, the cavernous sinus is free. You see the vertical segment of the carotid, and you can see the anterior genu of the carotid and vertical carotid. And here we are just cleaning the last remainings of tissue and of tumor in this case. We stop the video there. Play and pause. I'll go back just 1 second or so. Stop right there. Yeah, it's fine. So here, this is just to say, I mean, this view doesn't show precisely very well, but this is the anterior, the genu of the carotid. And then we got here, the horizontal segment is curving like this, and this here is the vertical segment. So this is the view that you can get. And here you see the medial wall is intact on the top. It's not intact in the bottom. So that's the difference that we were discussing before. So you see that that tumor being resected there, and very nice view. Let's play. And then you see here just coagulating, you know, some of the borders, like I think it's always worth to coagulate that this is an acromegaly patient. So we really need to push our resection to the best of our abilities there to achieve the goal, which is really disease control, hormonal control. And then reconstruction here. And then I see that you use, in this case, Noma dura substitute and the flap as well, right? I think maybe Dr. Olomo may have to have stepped out, but okay, let's show the results then, Chase.
So the pathology, the tumor stained positive for SF1 and PIT1. It was densely granulated for growth hormone, which is suggestive of the diagnosis pituitary adenoma somatotrophite. Let me pull up the pre-op CT here. And then here's the post-op day 1. And here we can't appreciate any residual disease.
But where's the soft tissue one that we discussed yesterday?
This isn't the soft tissue one?
No, yeah, this is the bone scan, right?
It's the soft tissue window. It was
No,
an
it's not.
maxillofacial.
No, it's not. It's
I
okay.
apologize.
That's fine. Okay, you can go to the next one. Oh, hold on. No, it's fine. I thought you had it somewhere. Okay.
JP, you just made me reflect on something. I think that we can easily do a study in which we can compare the outcomes, even my own, I can use my outcomes before you joined the practice and made me get into the cavernous sinus and look at extended resection of my own patient, just here in Mayo for the past 6 years. And I am 100% sure, well, 99.9%, because you never began, I'm 99% sure that will show that the extended resection has markedly improved. But that also means getting into the cavernous sinus and the outcomes, the hormonal control and everything. So we can easily do that study and show the world that these are techniques that are very valid, and training in this art is crucial. You know, and I can use myself as a case example. I'm not you know, I'm not afraid of letting people know that I still have so much to learn. But yeah, so I basically extended resection, outcomes, pituitary function, all those kind of things. Because see, the way that Dr. Rotan, Dr. Wilson, Dr. Loss taught us how to do these cases, that was the old generation, is to get into the tumor and to begin to debulk the tumor and never get into the cavernous sinus. That is the generation of surgeons that myself trained. All right, and that's how I trained my residents at Hopkins before I came to Mayo. But the way that you're doing this is an art that it is absolutely beautiful, and I think is leading to better outcomes, better resection, extended resection. And I think is worthwhile putting those. So you use someone like me with that experience and that gravitas and veritas, and say, this is what I learned, even for having someone like JP coming in and doing, you know, a much more extended into the cavernous sinus. You know, so I think that this is a beautiful study that we can do. It just came to me as I am about to sign off because I have another meeting. So there you go.
Thank you, boss, for the idea. I think the study is going to fail because I doubt that, but it's kind of like, but happy to take a look at that. Thank you for the suggestion.
Wonderful. Thank you. Well, I leave you guys continue, and I'm going to head out to another meeting. Thanks, everybody. Have a good weekend.
Appreciate it. Okay, Chase. So maybe let's take a look then at the hormonal result. That is going to be more I think more you know, interesting here.
So post-op day 1, she did have a growth hormone obtained, which was 0.72. Her prolactin was 18.6. Dr. Borsakova, would you like to comment on these results?
Yeah, I think that's one of the things where you can say the neurosurgeon have a great job, because on top of that, you know, like her growth hormone drop, you know, like less than one, which is actually surgical, you know, evidence of the cure of the disease. And also she didn't really has any pituitary, you know, hormone deficiency. She really has robust, you know, like cortisol after the surgery, which didn't require any steroids after discharge. Didn't develop, you know, like any DI, diabetes insipidus after surgery, and even on follow-up, like just recently, really doesn't have any pituitary, you know, like hormone deficiency. I'm sorry, I'm jumping. Yeah, this is a, you know, table, and her post-op 8, you know, this, you know, shows a growth hormone, you know, like less than 1 still. And also, you know, like IGF is, yes, still in, you know, like, and we see how significantly improved, but IGF takes up to 12 weeks to, you know, to normalize. It takes longer time, you know, like to normalize, but she's doing great after surgery. I just saw her and she feeling great.
But just so we understand, like I see that even I do agree with the delay in the usual delay in the response of IGF-1, but she has an IGF-1 at 188 in post-op day 8, which is normal for her gender and age, right?
Which, yes, yeah, and plus, you know, based on her age and, you know, like sex, which is really evidence, you know, for the cure and a good protective factor.
We like to see it drop, JP, but if it doesn't, we don't panic.
Oh, no. I fully understand. I'm just saying that it's nice to see that in this case, even in
Oh, it's
post-op day
fantastic.
8, it's there, because I mean, Dr. Sanson can certainly so further describe this, but it is very nice to see the impact of some of those techniques in our patients, right? Because when we look at a patient like this, and we would classify her, I don't know, NOSP 3B or 3A or so, and like in many series, if we go back in the literature, and you know, I myself have a couple of papers on this specific topic, the you know, disease control after surgery alone would be quoted on about, you know, 60 to maybe 70%. Some series would say even less than that, like 50%. And I think that we have been very, very blessed and very successful with the results that we have had recently, such as in this case, where we've been able to really achieve disease control with surgery. And that's, in my opinion, pretty exciting.
And then I just wanted to share this paper, and it was published by the team here at Mayo Clinic Florida, Dr. Sampson, Dr. Chachana, Dr. Q, and Dr. Almeida. And it looks at patients who had medial wall resection of their cavernous sinus, and if it impacted remission or disease persistence, and it was associated with disease remission. And it had very low incidences of intraoperative and postoperative complications as well.
Yeah, I just want to share one thing here. You see the numbers. So these are the 5 papers that we found in the literature last year. So we have here 5 groups, right? And we got, you see the number of cases in here, like 16, 14, 25, 102, of course, that's a big number, and 50, that's the UPMC series. So we have 13 last year, and what we are very hopeful is to be able to get, I don't know, maybe when we got to 25 or so, to start reporting our own data here from Mayo Clinic in Florida. Because it's the reality is that really, you know, not a lot of people are doing this. So it's going to be interesting to look at our own data and to see how we can further push this forward. Right now, with the 13 cases, we're talking about 92.8% of disease control, which is pretty exciting in my opinion. And I think that's it. Dr. Sanson, any additional comments? Dr. Vargas, Dr. Reiner, thanks. Always great to have you here, and it's been fantastic to work and learning with you as well. And thanks everybody. So it's already 8:10 or so, and we got to run and do some cases, but good to see everybody. What is happening on Monday, Diogo?
So we're gonna have Dr. Conover. She'll be joining us from University of Connecticut, and she'll be talking to us about the development and aging of the ventricular system and stem cell niche. So join us everyone on Monday.
Perfect. Thank you. Have a good weekend, everybody. Bye-bye.
Thank you. Thank you.